This is EHJ Today at the annual scientific sessions of the American Heart Association in Chicago 2014. I'm Tom Lucier, Editor-in-Chief of the European Heart Journal, and I'm talking today with Christoph Kaiser from Basel University and Roxana Meran from Mount Sinai in New York about the Basket Proof 2 trial. So the Basket Proof 2 is the newest baby of a family of trials. Tell us a bit how you developed this trial and what questions you wanted to address.
First of all, thanks for the invitation. Back in 2008, 2009 in Europe, biodegradable polymer drug-eluting stents came on the market. And the promise of these devices was to be as effective as second-generation durable polymer drug-eluting stents and as safe, especially beyond 1 year, as a bare metal stent. And therefore, very late stent thrombosis due to durable polymer should no longer occur. But there was no data out supporting this. This was just a hypothesis, and we said, come on, let's test it and let's do a trial where, with the question of the long-term performance of a biodegradable polymer drug-eluting stent compared to a second-generation durable polymer drug-eluting stent, and there we took the Science stent because I think this is the most widely used stent, and compared to a last-generation thin-strut bare metal stent. And the biodegradable polymer drug-eluting stent we chose was the bioluminescent-eluting Nobori stent from Terumo.
And the design was a randomized design?
The trial was a prospective randomized trial with a 1:1:1 randomization, and the follow-up or the endpoint was set at 2 years, so it was a long-term trial, even longer than the other results we had. And the primary endpoint was an effectiveness endpoint, and the study was powered for that, non-inferiority in MACE, so a combination of cardiac death, TVR, and non-fatal MI. First in biodegradable polymer versus durable polymer drug-eluting stents for non-inferiority, and then for superiority for biodegradable polymer drug-eluting stents versus bare metal stents.
So, of course, the polymer was the major question, but also what was the drug on the stents? Remind us for our listeners and viewers what the difference between these stents is.
Well, the Terumo stent has this biodegradable polymer on it, and it's a bioluminescent A9 eluting stent, so a limus drug. And the Science stent is an everolimus eluting cobalt chromium based stent with a durable polymer.
So there's also a difference between the drugs as well.
Yeah.
But of course, this is how in practice things are chosen, yes. And how many patients did you recruit?
Well, we included 2,291 patients.
In how many centers?
In 8 centers in Europe, 5 of them in Switzerland, 1 in Germany, 1 in Austria, and 1 in Denmark.
Okay. And was there any core lab involved?
There was no, there was no core lab involved because we had no angiographic follow-up, and there was only angiography allowed for clinical indication. So this was a pure clinical trial, clinical endpoint.
And what did you find?
Well, regarding efficacy, actually the biodegradable polymer drug-eluting stents per intention to treat was non-inferior compared to the durable polymer drug-eluting stent. So MACE rate was not significantly different, hazard ratio was 1.11. However, both drug-eluting stents were superior compared to the bare metal stent regarding efficacy, and this was mainly due in the first year. And this was mainly driven by a reduction in target vessel revascularization, as could have been expected.
Yeah.
Now, the safety endpoint, which was the secondary endpoint, a combination of cardiac death, MI, and definitive or probable stent thrombosis, showed no difference between the 3 stent groups, neither early or late. So there was no sign for a better safety for the biodegradable polymer drug-eluting stent compared to the durable.
And what was the event rate roughly?
The event rate for MACE was 7.6% in the biodegradable.
For 2 years now?
For 2 years, always for 2 years for the biodegradable polymer stent, and 6.8% for the durable polymer drug-eluting stent. However, it was 13% for the bare metal stent. But this was due to TVR.
Right. Which wasn't high either compared to the old series.
Absolutely, yeah. The TVR rate in the bare metal stent arm was 8%, which is not bad.
Yeah, it's actually quite good. And the patient characteristics, were they all stable coronary patients, or were there also ACS patients?
This was quite a real-world cath lab population. 2/3 of all patients had ACS, and 1/3 had STEMI. So only 1/3 it was stable. Yeah.
Right. So, what does the discussant think about it?
Well, I mean, I think first you should be congratulated in this day and age to do an investigator-initiated study in multiple sites in a prospective, randomized fashion with independent adjudication, which I think is extremely important, which was done in this trial, is difficult to do. We all know that. So congratulations on this study. What I loved about the study was the fact that it was contemporary. And I really actually liked the fact that there were 3 arms, because it really showed the evolution of where we've been, where we are, and where we're going. And for us here in the United States, that's extremely important, because many times we continue to look at older studies and use OPCs, and we all know about the drift from placebo and all of that. So I think this was really very, very well done. Another piece that I liked about your study is the 24-month follow-up, such that you can see what's going on beyond the 12-month follow-up, which is what everyone looks at, the 1-year follow-up. And the fact that you employed a more potent antiplatelet agent, prasugrel, in all of these patients instead of clopidogrel. So that piece of it also was unique and interesting and different than most of the trials that we see. So all of that was really great. The unfortunate and some of the limitations is that I think on the safety side, we're definitely not powered for any of those endpoints, because they were extremely low rates to begin with, and you'd need and I think Christoph already has it in his presentation, you need over 20,000 patients
for stent thrombosis.
For death MI stent thrombosis. So even though we have the promise of a safer, without a polymer, a safer platform, we don't know. And then after yesterday, with the prolonged DAPT, I think you start to think, do we or do we not? And should we even connect these to the stents, and should we just think about the patients? So I think in that way, we really can't say anything about the safety endpoints. On the non-inferiority for target lesion failure, or the MACE endpoint, I think you meet that, and you do meet your margin, your non-inferiority margin. But the event rates were even lower than what you had expected up front, I think, even lower, because over a 2-year period of a 7.6%, that's a pretty low event rate if you think about that, even for your... So overall, I think that this was really well done. I think it gives us some hope about these biodegradable polymers, and certainly the obligatory dual antiplatelet therapies, and maybe even a shorter duration, even though that's maybe a very bad word to use today, but we certainly would like to see that, and to be able to simplify the regimens for our patients.
Sorry for interrupting, but the prasugrel was given in a standardized fashion for 12 months, was it?
No.
Because this is also an important question, yeah? After these are safe data.
Absolutely. No, prasugrel was given for 12 months after ACS and drug-eluting stent placement, and only for 4 weeks after elective bare metal stent placement.
I see, yeah. So there's also a difference in terms of the schedule.
To interpret, and then lastly is the interpretation of what goes on from 12 to 24 months. Again, we're not powered to look at that endpoint, but these are all really still remain open questions for the different strategies of DAPT, the more potent agents, and then the off therapy, and whether or not you accumulate more events.
So what's the take-home message?
I think the take-home message is that these, based on our results, the biodegradable polymer drug-eluting stents are non-inferior compared to the durable polymer drug-eluting stents. But we have no sign for an improved safety. However, we are underpowered for that. But I think at the end, what we can say today is both stents are good, both stents are safe, and both stents are effective, and more effective than a bare metal stent.
Very good. Thank you very much indeed for coming. Have a nice day.